Hello, good morning, good afternoon, and good evening to everyone joining us today. I'm very excited to be here to share with you some of the case studies that were presented at the very recent International MiYOSMART case study context that was held at the IMC last year in Hainan. Today, you have presenting Dr. Tan Yan, who is a pediatric ophthalmologist from China. Martelie, who is an optometrist based in South Africa with a special interest in pediatric eye care. And myself, you're very lucky, I'll be here tonight as well. I'm an optometrist and I'm based in Sydney, and right now it is midnight. So I must really love myopia a lot if I'd rather talk about myopia at midnight than go to sleep. So I should tell you that just to reiterate, Dr. Tan Yan, Dr. Martelie Berger, and myself, we were all finalists at the case study context. And Dr. Tang took the crown as the winner for her very comprehensive and educational case study on early onset myopia. Now, look, I know I'm very much looking forward to learning from the two ladies tonight. And just before we start, I'd just like to take the time to thank Hoya for the very unique and innovative opportunity to share our case studies on a global stage. The program was obviously held in beautiful Sanya in China, and it was very generously hosted by Hoya. So I really would love to see more people become involved in the future, because really this is how we all grow professionally, by sharing and collaborating, so that ultimately we can have the best outcome for our patients. So if we can just start with a poll. So which myopia control intervention do you prescribe the most? Do you prescribe myopia control spectacle lenses, myopia control contact lenses, orthokeratology, low-dose atropine, low-level red light therapy, the one that you prescribe the most often outside of combination therapy? And the results are MiYOSMART lenses. Considering that particular lens has only been available in the last few years, it is quite interesting how myopia-specific contact spectacle lenses have become such a popular intervention across the board. Let me introduce tonight's first speaker, Dr. Tan Yan. She is an expert in the field of myopia and will be presenting a case study on high myopia in very young children, and will illustrate different cases and emphasize the importance of combination therapy for effective myopia control. So please welcome Dr. Tan Yan.
Today I will share about 3 cases. One by one is more younger. The first children is about 4.8. Oh, it's come to the poly question. You can begin. You can begin. The poly question is about when you see a children that was 4.8 years old who have myopia, about a very low myopia, what you will choose. What treatment you will choose. In a few seconds, we will see the results. And today, I will share about a very young children that 4.8, and another is 2 years old, and at the end of the cases is 1 year old. So let's see. Okay, I think most of you will feel you can just follow up. Okay, let's begin these cases. He was a young boy, about 4.8 years old, and he's a Chinese boy, and his father had -5 myopia, and he was a totally studying boy, and he do not have enough auto activities, but his eyes we check are normal, So here we go. We can see the eyes change. At the first, his parents did not choose to wear the glasses. At what you guess, but the eyeballs actually change very fast. At the first 2 months, it had changed about 0.1 millimeters. Group. So the parents have chosen the MiYOSMART glasses to help him to control the myopia. You can see in a very long period of time, it was amazing. The eyeballs actually controlled very, very good, and it almost stable. But for about 1.5 years, something changed. The children had went to school. What happened? They went to school. It was about 6 years old boy. It changed very, very fast. So the parents want their children to not always wear glasses, so they choose to wear ortho contact lenses. You guess ortho contact lenses, is that better than the MiYOSMART glasses can control the myopia? We haven't get the surprise. It also changed very fast. At about 2 months, as what you guess, it's changed very fast. In 2 months, it have changed almost 0.1 millimeters. So this time we use the ortho contact lens, also combined with 0.0 atropine, but you see, it's still very quick. So when we combine with atropine at about 2 times a day, it comes to stable. So let's get a conclusion. You see at the 4 years old and 5 years old, it's very stable. At the 6 years old in the primary school, it's not very stable. If we change the ortho contact lenses, it's more the speed is more faster than just wear the MiYOSMART. But combined with atropine, it will be stable. So it's not a very difficult cases for us to control the myopia. We got a conclusion of he wear the MiYOSMART. Did he have some navigate bad effect of the eyes function? You see both the NRA, PRA, and the both eyes function are not very bad. And the second the cases two was a 2 years girl. And you see he was a Chinese girl, and unfortunately, her mother has RP disease. His father is a very healthy eyes, has a very healthy eyes, and he has very long time for outdoor activities. His left eye is 0.27 myopia. The right eye is very low myopia. You know, the eyeballs actually are very short and not very long. But we see the fundax. Oh, it's very the triangular are very thin. It has a lap of change. So we can see the also OCT. You see the triangular just think at 1.55 micrometers. So let's get a review of her. You see as what we guess, we first just wear a single vision lenses just to make sure do not amblyopia. But you can see it changed very fast of the left eye. The left eye, the eyeballs ratio was changed 0.8 millimeters 1 year. So the parents have changed another kinds of blurry glasses. In the central is blurry. In the peripheral is blurry, and in the central very small area is clear, but it not works. You see the eyeballs actually still grow very fast. It's about 0.51 in 1 year. So this time, the parents have chosen the MiYOSMART. Oh, you can see the surprise after wearing the MiYOSMART. About 1 year, its growth will changed very stable. It's about 0.140 and 0.22 per year. And You see this is the refraction change. You can see after wearing the MiYOSMART, it's very stable. So you can see the MiYOSMART can works better than the single vision lenses and such like the peripheral blurry lenses. And she was a very, very young girl. So we adopt that if he wear the MiYOSMART will make the blur with the amblyopia. Is that true? I think not. Her visual active grew at the same age of the average young person. And the third is a more younger boy. He was 1 year old, and you guess what we have done for him. When he first come to our clinic, hospital, he was just 1 year old and 9 months. Both his father and mother have almost -6 myopia. And his parents were very, very nervous about him because after the cyclopia, the refraction use atropine, he still have myopia. It was -3.50 and have astigmatism -2.25. And also the eyeballs X-ray was very long. And you also see the fundax is a really something like the middle change of the high myopia change. You can see the OCT extraordinary thickness also very thickness. It's about 169, 167. Oh, what should we see? What should we do? We have done the genius test. Fortunately, we haven't find any of the high myopia single gene changes. So we haven't find the gene, but his myopia and eyeballs actually changed very, very fast. We firstly just use the single vision glasses and use the 0.0 atropine. It did not work. About the first 6 months, the eyeballs actually was change about 0.30 micrometers. And we change another way. We use also the MiYOSMART glasses and combined with 0.05 dozen atropine Q-night in Beijing. You see, a little bit works. It had been more slower, but the parents also very nervous. Is that enough or not? So at the end, they went to the Sanya. It's a province in China. It was very warm and always have a lot of sunshine in the front of the beach. They go outdoor activities about 5 hours a day. And more walks. You see this time, half a year is changed about 0.80 millimeters. And you see this is the refraction test, what is changed after he went to Sanya. It was more stable than use the normal glasses, and the MiYOSMART is more better than the normal glasses also. And let me give you a conclusion of the visual active. It was be better and better. So let's have another polling question for you. Please, Andy. Oh, so I will ask you the polling question. When you find the children have this high myopia, what do you think after he went to Sanya, 0.22 millimeters half a year change is okay? Or we should choose another way to help him to control the myopia? Okay, I think about the most doctor will choose to change another kind of glasses, and the other most choice is to make the atopian the more dozen and more times. Okay, let me give my result. We have used many times to talk with their parents how we can help these children. But at that time, in China, we have a kind of a rapid low-level red light therapy in China. But for this very, very young age people, we do not have many experience. But we have a try because his parents just wondering if the children need surgery. Um, the clear, clear make it more stronger, but they just choose the LL red light therapy. You can see that here. At the first, we haven't used it. It's about change 0.6 in 5 minutes, 0.12 in 5 months. But after use this therapy, it have changed, come back again. The eyeballs actually be shorter, about 0.22 in 5 months, and the left is 0.12 in 5 months. It was very amazing. So today let's come to the discussion. First, I want to see for the very, very young age people, it was very challenge for us. We need to help them to control the myopia, to help them to avoid the retina disease, also the cataract, also the glaucoma, but we do not have many ways. We just use such like MiYOSMART or 3 contact lenses or atropine, something like that. And firstly, I want to discuss is that MiYOSMART have negative impact on the visual development. I think the answer is no, because we have tried many very young children, it really can focus on the macular, I think. In the peripheral, it cannot focus, but it not avoid the visual development. And do you think the MiYOSMART lenses such like can negative impact on the visual function? I have found many college did the support. They have give us the answer that did it not negative for the visual function. After we have tried on the first cases, we also find the same result. And the discussion 4 is will something like the glasses, such like MiYOSMART, will more effect on the such very young age children. I think the answer is yes. It's very difficult for us to choose the ortho-K contact lenses. It's very difficult for us. We do not let them wear any glasses to correct visual active. So I think maybe for them, it's a very good way for them to choose MiYOSMART, because sometimes I think the DOT glasses, the visual function a little bit weaker than the MiYOSMART glasses, in my opinion. I'm not sure. You see, after let's get the last discussion. What should we do if the MiYOSMART is not effective enough in control the myopia? We are trying to find many ways to make it balance. If we just use one glasses, it's safe and effective, we can use it. But sometimes it was very difficult for us. We just need to try the eye surgery, such like clear reinforcing, or when we use the red light, we also atropine, something like that. We just need to make a balance. I think the key is to improve the clear hyperopia can be the king of the myopia control. You see, after using the red line, the trajectory was thinner than before. So I think the most important is safe and in fact and easy to follow. So let me guide a conclusion. I think MiYOSMART is a good choice for kids with myopia, even for children under the age of 5. It's more difficult to control the congenital myopia progression, meaning occasionally, individually, and comprehensive solutions are also needed. Okay, thank you.
That was excellent. It was very insightful and interesting for you to be presenting case studies on a 4-year-old, a 2-year-old, and a 1-year-old. And I actually found it quite interesting when you said that the ortho-K, that when they wore the ortho-K for the 4-year-old, their progression was faster than MiYOSMART lenses. So that was an interesting observation to see. You mentioned the use of repeated low-level red light on a 3-year-old. I'm actually quite amazed you can get a 3-year-old to sit down to look at the red light twice a day. So if you can maybe give us some hints and strategies on how you can encourage kids to sit and do anything, because I can't get them to sit down and do much for very long. What I actually wanted you to do, Tan, if you don't mind, is maybe for those who don't have access to the low-level red light instrument, to just maybe talk about what it is very briefly, to explain to them what this treatment is, because they may not have it available in their country.
Yeah, it's a kind of light that just have one, one light. It's just in about 530, you know, 530 the power. And you use it about 0.2 micro-V. You know the unit? 0.2. And just use 3 minutes a day, two times.
Yes.
And when they use it, they just listen to the stories or something like that. After they use it, sometimes they will feel they see something more clear and more lighter. So the children can follow this therapy very easily than others. He was a very young children, but he can follow it and he like it.
Yeah, I'm amazed that you were able to get him to sit down for 3 minutes twice a day. Do you believe that combination therapy is going to become more important as time goes on as an intervention strategy?
Yeah, I do think so. Because I think just one one therapy is not enough for this quite very young children. I think comprehensive is we really need. Yeah.
Yeah, yeah. Well, I have to say, Tan, I always learn a lot. And even though I've already heard your presentation before, I learned more things again. So you explained some, concepts in a very clear and an engaging way. And I want to thank you for being such a great leader in the field of myopia management. So congrats
Thank
again
you very much, Jenny.
for
You
winning
really
the
helped me
inaugural.
a lot.
Yeah, well, congratulations again for winning the inaugural MiYOSMART case study contest. I'm sure there will be lots of questions that will come from your presentation. So our next talk will be given by Martelie Berger. Martelie, as I mentioned, is an optometrist based in South Africa and has a special interest in pediatric eye care. She runs a pediatric-centric practice and holds a professional certificate in pediatrics from Aston University in England. So tonight, you're in for a treat. She's going to present an interesting case study on how to manage high astigmatism and whether or not full correction should be applied in very young children. This is certainly a challenging cohort of patients, and I look forward to hearing your recommendations, Martelie.
Okay, thank you so much for the introduction, SooJin. I appreciate that. So today I want to just talk a little bit more about correcting myopic astigmatism in very young children. So I took this case because this case is very close to my heart. I want to protect this child from the genetic consequences that his family has faced over the years. And how exciting for optometry worldwide that we can alter a genetic pathway. Focusing on his family history of severe myopic complications, it is evident that he would likely encounter similar results if his myopia is being left untreated. So all males on the maternal side over the age of 50 have or had visual loss that could not be corrected due to the complications of my myopia. My greatest wish is to manipulate his genetics and change his genetic destiny for good. I aim to provide him with a better opportunity in life, free from the bleak possibility of permanent, uncorrectable vision loss. One of the most difficult decisions I had to make with this case was to fully prescribe for his astigmatism at the age of 3, or to partially prescribe as we do with our regulations, because we know astigmatism can still very much change. We like to underprescribe, depends on the age of the patient. My other concerns with this patient was that will the patient be compliant, and will the glasses survive a 3-year-old boy? So now, looking at the case history, the patient is a Caucasian male. His current age is 4 years, 5 months. The age of onset for the myopia was 3 years and 1 month. Like I said, with his family history, myopic astigmatisms for the male on the maternal side, ending up in high myopia. The mother has low myopia. His grandfather had normal tension glaucoma and a macular hole from the age of 45. So he had never had an optical correction previously to the 3 years, 1 month. And because we live in South Africa, outdoor exposure, I said between 2 and 3 hours, but it can be much more than that. And his close work is limited to 1 to 2 hours a day. So the pregnancy was uncomplicated. The mother had a C-section, elective C-section at 38 weeks, 5 days, with no complications. He, however, had quite a few hospitalizations in his first 2 years of life. At 3 months, he was in NICU for 7 days with viral pneumonia. He was again hospitalized for the RS virus at 6 months for 1 day. He had grommets at 12 months. He had a very serious Coxsackie virus infection and tonsillitis at the age of 18 months that kept him in hospital for 4 days. And then he had a second set of grommets at 18 months with a tonsillectomy following his severe tonsillitis. So his development was a little bit delayed. He could sit at 6 months. He crawled at 12 months. He walked at 16 months. His language development is in the lower range of normal currently. He had the abnormal gait until the age of 3 years, 7 months. So currently he's still slightly delayed in his gross motor development. However, he outgrew a lot of his allergies that he had that caused all his ear infections. And he's currently taking no medication and a healthy young boy. So I'm going to take you through my test results. So like I said, the first evaluation was at 3 years, 1 month. So obtaining an unaided VA for a 3-year-old can be quite tricky, because often you don't know if they just don't know what you're showing them, or if they're shy, or they just uncertain. So to make sure that he did have reduced visual acuities, I usually do my visual acuity test twice, once with a pediatric test target with a Spectrum software, and then repeating it with the card of test cards to confirm what I did get was accurate. Then I relied greatly on Mahindra Red. So the initial evaluation, we started with the Mahindra Red of minus 050, minus 225, axis 180 on the right, minus 050, minus 175, axis 180 on the left. And as you can see, Mahindra is one of the techniques that ends up being very close to a cycloplegic refraction results. So we got a slightly reduced calculation or findings with the cycloplegic refraction than we had with Mahindra Red. But often I will do on the follow-up evaluations, I won't always do a cycloplegic refraction, because if the Mahindra Red showed there was no myopic regression, I won't feel the need to do the cycloplegic refraction again. However, if there was a myopic shift, I would definitely do the cycloplegic refraction, as it is the golden standard that we have to do. As you can see, the K readings was a slight corneal astigmatism that we see there. The actual lengths was quite within the norm. And if I could get, there's actually no tips I can ever give with the current equipment for measuring actual lengths that is available to me that can make it easier to test a 3-year-old. So it just took multiple measurements, bribery, corruption, just to get him to comply, to get actual length measurements from him. But then we went to look at the spherical equivalent. And on the right, even the myopic compartment is small on the script. We sit with the spherical equivalent of minus 125 on the right and minus 1 on the left. Stereo acuity was fine. There was a slight reduction in his distance stereo acuity. Heidi contrast sensitivity test was normal. His MEM results was normal. Binocularly, there was not really anything worth mentioning. And we ended up with an aided VA of 6.6 in both eyes. So when we got this result, I really had to decide, are we going to prescribe fully? I'm going to do a partial prescription. But I end up going with prescribing the full cycloplegic refraction. And when I test him again in 6 months' time, everything stayed very similar, except that we had a slight reduction in his astigmatism on the right eye, even though we gave the full prescription. So that was a great relief when I saw that. Everything else stayed quite the same. What was also encouraging was with the higher MEM rate that I got at the 6 months evaluation compared to the month before, or the 6 months before, even though it was over a lower minus prescription. Then again, 6 months later, we repeated the exam again, and everything stayed almost exactly the same over the next 6 months. And the only other thing that was worth mentioning is that on the near cover test, I did find a small esophoria movement. And this brings us to our poll question. So, Andy, if you can just put up my poll there. So in practice, do you find that myopia progresses more with a patient with esophoria or exophoria or esophoria apnea? If you guys can just take your time and answer that. Okay, yes. Okay, so what I saw with the research is that studies have showed that with esophoria, we often see that there's a slower progressive myopia, and they say that it might be because of the increased convergence efforts. But I have to say for myself, in practice, it is often, sometimes it goes that way, sometimes it don't. So I will be really monitoring this patient closely with his emerging esophoria. So after my initial tests, I sat with a differential diagnosis in my head. One would be myopic astigmatism. The other one would be accommodative excess. not doing a cycloplegic refraction, you always at this age group can have over-accommodation, accommodative excess, increased astigmatism due to the over-accommodation. So very important that the cycloplegic was done to be able to rule out accommodative excess. And then with these corneal astigmatism, we will always be on the lookout, for possible emerging keratoconus. But my final diagnosis was myopic astigmatism, and therefore I prescribed the DIMS lenses, MiYOSMART, for the whole treatment period, so this far. Okay, so with the little research available on myopia management for this age group, when do we start myopia management? For hyperopes, we're quite rehearsed, and we know, from birth, if there's an esotropia, you prescribe your full plus and almost overplussing them at that stage just to get everything straight. And, there's no confusion for us. But with myopes, it's a little bit more daunting. And I believe we should not be scared to prescribe for young myopes. Like adults, they actually also value the quality of clear, comfortable vision. Even more so, it is critical for early development in life. If we know what we know about myopia and myopia progression, should we not rather look at the spherical equivalent and not at the astigmatism? I think if there's one thing that is engraved in my mind after my studies at Aston, it was Prof. Logan that said that every letter on the VA chart counts. Therefore, giving the full prescription for better acuity as well as myopia management was the right thing for me to do. Because I believe to start myopia management as soon as possible, with this case, it gave me great comfort that we saw the reduction in astigmatism, even though the patient received his full prescription, and no myopia progression took place for this period. Another thing that I feel very passionate about is then also the dispensing. So with this young boy, it took regular frame adjustments, intense parents' education, and frame hooks to keep the frame in place. The parents could then adjust the frame at home with the frame hooks to make sure that the child is looking through the optical zone for the majority of the time. I feel passionate about the anti-reflex coating. As we know that with development delays and reduced VAs, that it is best to prescribe the anti-reflex coating, a good quality one, to ensure best optical clarity. These lenses also needed to be replaced at the 6 months follow-up evaluation because it was scratched badly. And I'm not talking about the normal wear and tear type of scratches. He explored by scraping his glasses on a brick. So if I can have one research question, it would be, is underprescribing of astigmatism still the golden standard if the spherical equivalent is myopic? Or does it contribute to myopic progression? Then, how do I get a child to wear glasses? This is possibly the most asked question in my practice. With this young child, it took a whole 4 weeks for him to get comfortable in his glasses. In the beginning, he will take them off, compare vision with and without. So all the caregivers was advised that this would be normal and they should just put the glasses back on as often as possible without making a fuss. After 4 weeks of his sensory world gradually changing, he did not want to take the glasses off anymore. As you can see for yourself, he literally goes to sleep with his glasses on. And it's the first thing that he looks for in the morning when he wakes up. In a very short time, he had no problems to adapt to design and his new sensory world. Dispensing is often overlooked, and I believe with accurate dispensing, MiYOSMART will have even better results. Finding a frame that was durable and active for this exploring toddler was essential. So as you can see from the bottom picture of him peeping over the glasses, that it's an ongoing challenge, and that's why the whole parental system and caregiving system needs to be advised on how his glasses should fit for him to have active treatment zone majority of the time. So my treatment strategy for this patient was definitely DIMS lenses with his full prescription, rather focusing on the spherical equivalent than the astigmatism. By saying that, it means I rather fully prescribed his total astigmatism prescription and not reduced his astigmatism prescription. I did a dispensing check at 2 weeks. It's often very important. Make sure that the parents still understand that the glasses need to sit correctly. You double check that they actually are. And then for the remainder of his childhood, we will do 6 months follow-up evaluations. When it gets to the compliance of the treatment, we need the parents to understand the need for the glasses. And with the need of the glasses also, we need to explain to them that they need to limit screen time. They need to play outside and they need to actually wear the glasses for it to work. I find explaining myopia management to the patient on a scientific way works well. If they get the why, then they always comply better. And then we also should remember it is equally important to reiterate visual hygiene. Screen time, outdoor time, is so important in the treatment of myopia that it cannot be left behind. What I find with the toddler and screen time, the answer is rather no screen time on a tablet and a cell phone than 20 minutes, because I don't know about you, but picking a fight every day with a 3-4-year-old is not my favorite time. So I would rather say, no, you'll fight for 2 weeks, and after that, that becomes the new rule. So my takeaway message for you today is every letter on the VA chart counts. It is never too early to start myopia control. Adaptation is better than you would expect, and dispensing is a key to the success. Damaging the lenses is going to be a reality, and concentrate on the spherical equivalent with myopia control when deciding when to prescribe. In the last year, we compared this child that was not able to draw himself at the age of 3 to a child that is now self-assured, boosting with confidence, participating in sports, and improved beyond expectations in his all-over development. And the self-drawing you see there is a portrait to prove it. We see in practice the success rate is far higher than the 60% reduction rate that the research is showing for MiYOSMART lenses. That is when the patient is compliant. I thank you.
I'm actually really impressed at how comprehensive your review appointments are, Martelie. Like, you actually do so much every time they come and see you every 6 months. Is that your routine for all your patients?
I took great care with myopia because, one slip and you miss a year or you miss a 6 months visit and you get a 50% reduction. So my follow-up, I often do, if they're that young, over 2 appointments if the concentration does not last. But yes, that's what I do with every 6-month follow-up.
That's very impressive. And I noticed that you take keratometry readings as well. Is that something that you do routinely for patients with astigmatism, or is it something that you do for all of them?
It's something I do for all of them, and I have to just credit the equipment that I've got. It's an auto handy ref, so it's a mobile unit, and I just do it in any way. So it did make a big difference on my clinical outlook. And what I just want to reply on the previous question as well, maybe when they're 8-9 years old, I won't be so comprehensive, but at this young, delicate age, we really took our time. Yes.
Yeah. And you're right in when you said that it's really exciting to think that we are here today as eye care practitioners providing treatments that can actually change the projection of someone's refractive error. and not just change their final prescription, but also potentially, you know, give them a quality of life that is improved. We are definitely living in the golden age when we have all of this new research coming through. So well done, Martelie. That's an excellent presentation. Now I'm going to start my presentation. So this is me with two of my favorite myopic patients. It is my pleasure to present a case study on a young child with syndromic myopia. We will review the protocols outlined by the International Myopia Institute and how to manage these kids. And we know this is important because about half of these kids with high myopia actually have an underlying systemic general health condition, and you and I do not want to miss that. Here is just a little quick snapshot of some of the diagnostic tools we have available at our practice in Sydney. And here is a little snippet of what Eyecare looks like in Australia. This study shows that there are about 1,000 ophthalmologists and just over 6,000 optometrists providing eye care to a population of about 26 million people. So in Australia, you can have eye care done by the optometrist, and if you need tertiary care, you get referred. So here is the scope of optometry practice in Australia. We have about 7 optometry schools. The degrees are about 5 to 7 years. We have 60% that work in corporate optometry and 40% in private practice. I know that different countries have different ways of delivering and providing eye care to the community, and I thought I'd just provide a little snapshot of what we do here in Australia. So let me introduce my case study to you. This is Kaichi. I first met Kaichi when he was 4 years old. His mother had brought in a prescription from the hospital and wanted a second opinion. So you've probably met lots of kids like Kaichi. He's, you know, a little boy who is so bright and sunny and beautiful, and he's really afflicted with the wiggles, and he just couldn't sit still during the eye test. He's just so interested in everything that's around him, and I really empathize with what Martelie was saying, because every visual acuity that you can get out of them does count. And I had to chase him to measure his visual acuity, which really turned out to be reduced. And, you know, myopia in young children is not very common. So this case study is really about how we manage those kids. Now, if we look at the prevalence of myopia, you can see that myopia in children under the age of 5 and 6 is very rare. It's estimated in China and Singapore, the prevalence rates are only, 0.03 to 0.2. For kids that have myopia, that's worse than -6 diopters in children. And in the US, the prevalence of, you know, myopia worse than -4 is really low, and it's only like 0.6 to 0.8 in 5 to 6-year-olds. So really, the point that I wanted to make in this presentation is that we need to be mindful that children with high levels of myopia in early childhood do not progress at the same rate as school-age children who develop myopia later in life. And there are 2 main types of genetic etiology. We're hopefully all collectively quite familiar with the school-age progressing myope. Most of the myopia intervention studies include subjects that fit into this profile, but when it comes to children with syndromic myopia, they're excluded from studies. And so, and of course, this is so that the results of the study are not confounded. However, for people like us, and this is why so many of our case studies from Martelie and Dr. Tang, we're focusing on young infants with high myopia because it really makes it very hard for us to figure out how to manage this special group of patients who really, they need us more, if not less, to manage their eye condition. So here are some syndromic myopia conditions that you may present with in your consulting room. And this particular diagram, which is a little difficult to see, demonstrates the genes which have been identified for both common refractive errors and syndromic myopia. And as you can see, there are a lot of them. And that's pretty much all I have to say about this one. Now, For an infant or child with high myopia that warrants a closer assessment, the IMI provides a management path with clear instructions on what to look for in terms of relevant findings and the actions you can take. Obviously, start by taking a detailed history to identify syndromic forms of myopia. You don't want to miss that. Ask about birth history, developmental milestones, and any other signs of developmental delays or health issues. If you have the knowledge to do so, examine for non-ocular findings or even observations to see if they need a further review by a pediatrician. Assess visual acuity. This is key. It's really important. It's what we do. Assess visual function and color vision, as it could help differentiate children with retinal dystrophy. And after you've ticked off all those items from your eye test, here are the next steps in the flowchart. Okay. Take axial length and corneal topography measurements if they are available in your clinic. They are certainly very useful information to have. Check eye movements, pupil reaction, and you'll miss clues if you don't do a slit lamp, even if it's difficult to do it on a young child. Measure IOP to rule out congenital glaucoma, and ocular imaging, if possible, on younger children. I know it's not easy. I also know that not everyone will have access to this information, but if you do, they will certainly help you with an earlier diagnosis. Now, electrophysiology, which has been mentioned by Dr. Tang, is not a routine test optometrists might consider as part of their battery of tests, but it is an important consideration for potential referrals, especially because they are essential for detecting conditions such as retinal dystrophies. So let's go back to Kaichi. Now, Kaichi, fortunately, had a very normal developmental history with an uncomplicated full-term birth. If we look closely at his risk factors associated with progressing myopia, we know that Kaichi's mother is Asian, she is Japanese. He was only 3 when he was diagnosed with myopia. His father is myopic, and he was initially prescribed single vision lenses from the hospital, which, as we all know, has no myopia control benefits. Like, we're very fortunate in Australia because, like many Aussie kids, he loves spending time outdoors. So I know for him, time outdoors was not a problem. So our story with Kaichi starts here. This is when we first met with his myopia, and he looked like he may have had reduced visual acuity. At the first visit, I tend not to worry too much because it might just be him, might just been the child not paying attention. But I want you to look at how his prescription has changed over the last 4 years and how his best corrected visual acuity has only ever been, if you have a look, 612. And note how the initial rate of progression was initially 1 diopter per year, and now appears to have slowed down to, say, 0.375 since using combination treatment, and in this case, MiYOSMART lenses with low-dose atropine. Now, this picture with his glasses dropping down, and I love that Martelie also made a point about how important fitting is, and really, as good as we are as eye care practitioners, we obviously focus on providing the most comprehensive eye test. Dispensing frames and lenses, honestly, are equally just as important. Got to pick the right frame, got to make sure the lenses are fitted correctly, and have to make sure that the child knows how to put them on and take them off so that they don't damage the lenses or their frame. So here is a little snapshot of Kaichi's binocular vision, which you can see is quite stable, with the only notable finding of reduced lag of accommodation. And this is even with the use of atropine. Didn't really seem to be making much of a difference for him. Now, atropine also doesn't appear to have caused any significant change in pupil size. Here is a little normative data of what you expect a child to have for their pupil size, and his was pretty much on average. There wasn't really much to be concerned about there, and he wasn't terribly concerned about any light sensitivity that didn't seem to be affecting him at all. So Kaiichi has some pretty symmetrical average-looking corneal curvatures with, around 42 to 43 diopters with a small amount of with the rule astigmatism. And if I go into this chart here, Kaiichi was into this axial growth chart, now refractive growth chart. Kaiichi was -4 in the right eye and -4.25 in the left eye at the age of 6. If we plot this on the refractive growth chart, it predicts his prescription to be -13.5 in the right eye and -14 in the left by the time he's 16. Now, I know what you're all thinking. To be fair, predicting the actual myopia progression in a really young myope is not very predictable. I know. But that's not the point of a growth chart. For me anyway, as a clinician, whenever we have a plan to manage a child, we want to have an end game. And if I'm explaining this to a parent and they look at this chart, you get a sense of potentially, because it is relevant for a lot of kids, of how bad his prescription could become. And it creates a sense of urgency to do something today. One of the questions that was posted was, how do you get the parents to engage with myopia management? Explaining to them why myopia management is important to do today because of what might happen tomorrow gets buy-in from the parents. After all, when do we make the biggest impact? We make the biggest impact with myopia control when we start as early as possible, not later. Now, if we have a look at the axial length growth chart, we notice that Kaiichi also had really long axial length in both eyes at the age of 6. The clinical pearl for using axial length growth charts, such as this one, which is from the Tidman study, lies in identifying those that are at risk of developing high myopia. We know that longer axial length is associated with pathological myopia, and we all know this is the why of myopia management. So an important clinical goal is really to keep axial length less than 26 millimeters. Now, here are some axial length measurements that I have for Kaiichi from the age of 6 with progressive changes compared to baseline. And if you look, because I did put in the changes over time, they do actually appear to be slowing down. And I wanted to make a note here about refractive and axial growth charts for everyone, and that is that these charts may not be relevant for all children, especially those cases who have been excluded from studies due to confounding factors. So when I see a patient, and this is every person who walks in through the door, they are an N of 1 to me. Kaiichi is not a cohort, is not a statistics. So whilst all the tools and comparisons are useful, patients like Kaiichi deserve individualized care and management. So understanding why he is progressing myopia and then providing a more tailored care for him is really what we're trying to do. Now let's look at some retinal pictures. In the right eye, you can see marked obliquely inserted optic nerve heads with prominent temporal peripapillary atrophy. We can also see progressive retinal and choroidal thinning temporal to the disc, creating this, like a tessellated appearance in just 3 years. And a tessellated fundus is associated with thinner macular choroidal thickness. And just in case you were wondering, I did leave this here. The left eye has a similar appearance. Here are some OCT images of the optic nerve heads. The neuroretinal rims appear healthy. It is obviously clear that the discs are unusual, and we have to remember that there really is no normative data for young children anyway, so we have to look at it case by case. And when we zoom in a little closer, we get a feel of how tilted, crowded, and obliquely inserted the optic nerve heads are. Now, just to have a look at the macular region for the right eye. It appears a little thin, but relatively unremarkable. The retinal scan doesn't really explain Kaiichi's reduced visual acuity. However, if we zoom out of the OCT image of the macula, we find that Kaiichi from the age of 6 already had signs of bilateral posterior staphyloma secondary to myopia. Now, I don't know about you, but I find it quite alarming to think that staphyloma can be present in such a young child. And that was the image for the right eye, and I can show you the image for the left. And in fact, the point to make here is that staphyloma in young children with myopia is actually not that unusual. In fact, around 13% of highly myopic children will have signs of posterior staphyloma. And I wonder how many of us actually actively look for it when they come in for an eye test. So, diagnosis is really important. And when things don't quite make sense, we all need to remember to refer patients out for further diagnosis and management and do what we do best, which is to provide the highest level of evidence in terms of myopia management. Obviously, in Australia, we've got optometrists providing primary eye care, and then we have ophthalmologists who can take on all of the more complicated cases for tertiary care. Now, the IMI white paper has a flow chart on indications for referrals for infants and young children. I think it is reasonable that as primary eye care practitioners, we are able to recognize risk factors that indicates referrals. Some of these children will require a team of professionals to look after them, and this could include ophthalmologists, especially those who specialize in inherited disease, clinical geneticists, genetic counselors, pediatricians, as well as other allied health professionals. So, going back to Kaiichi again, after a few years of persistent reduced visual acuity, and we had been co-managing him with the local hospital all this time, I finally decided he was ready to go back and get a second referral for further testing because his visual acuity was just not getting better, and it didn't make sense. And fortunately, the hospital specifically noticed optometrist concerns of reduced best-corrected distance visual acuity. And we finally had a reason for why. Kaiichi had congenital stationary night blindness of the incomplete type after he had electrophysiological testing. And appropriately, he was then referred for genetic testing. So what is congenital stationary night blindness? It is a condition where you have impaired rod photoreceptor function, leading to poor vision in low light. And this is why a lot of them end up having poor visual acuity, and a common symptom is, poor vision at night. Congenital night blindness is also associated with myopia, and there's no specific power that they're related to. They can range anywhere from low all the way to high. And if we look at this particular study, you'll find that it's quite interesting because not all patients with stationary night blindness will present with the same symptoms. The most common ones are visual acuity. At presentation, only half of them will complain about poor visual acuity. Maybe that's because they're young when they're first identified. And but by the end of follow-up, they do recognize that they have it, and that might be because they're being tested during school years. And other common symptoms would be, followed by nystagmus, poor night vision, and myopia. This diagram categorizes stationary night blindness into 3 main inheritance patterns. And you can see that the most common one is the X-linked, where it accounts for 57% of all the cases. The X-linked form is often associated with both the complete and incomplete forms of congenital night blindness, which do differ in the extent of retinal dysfunction. If you remember, Kaiichi was diagnosed with the incomplete form of stationary night blindness, and his specific genotype was CAC-NA1F. Now, the incomplete type is due to a dysfunction in both the on and off bipolar pathway, and it's associated with a wider range of refractive errors. Some kids with the incomplete congenital night blindness even manifest as hyperopes. The complete type is due to a dysfunction in the on-bipolar pathway, which is associated with a more severe myopia. And you can see how the myopia progression for the incomplete type is slower. Most of the refractive changes happen in the earlier years rather than later years, which is in contradiction to kids who are school-age kids, where they progress faster as they, as they go into school-age years, and then slow down as they grow older. So the expected rate of myopia progression is about half a diopter over 2 years. And, should we be worried, especially if progression is slow, compared to, school-age kids who progress more than 1 diopter over a 2-year period? And my conservative answer is yes, we should. They will still benefit from long-term myopia management, because we know from research that every diopter counts. When you reduce it, you also reduce the risk of ocular pathology. So here is a little pretty picture of how light is transmitted through the retina and how we need all these cells to talk to each other in order to see what we see in our brain. Now, bear with me. I'm going to go through some of these slides really, really quickly, but there's a rhyme and reason for all of this. Now, congenital night blindness, as we mentioned earlier, is an inherited retinal disorder. And the defect is the defective visual signals are between photoreceptors and bipolar cells. This affects vision in dim light. This is why kids like Kai Chi find it difficult to see at nighttime. The key areas are the retinoid recycling in the RPE layer, the photoreceptors, and the rod-on bipolar cell synapses. I'll just make a quick note that most of the forms of stationary night blindness, the retinoid recycling in the RPE isn't really directly affected. Now, just as a reminder, I have to remind myself when I don't see things for a long time, but I'm sure you all remember your rods and cones. They are special cells called photoreceptors that respond to light by generating electrical signals. Cones, which are in the macula, respond well to bright light, and rods are sensitive to low light as well as peripheral. Now, you might recall that I mentioned electrophysiology was essential for diagnosing retinal dystrophy. And this study, with those red ones moved out of the way, demonstrated that young children with high myopia had reduced responses of cones and rods compared to school-age onset myopia. Findings like this can really help with early detection and provide better tailored interventions for high myopia. Now, when rods and cones detect light, either increasing or decreasing, they send signals through 2 main types of bipolar cells: the on bipolar cells, which activates when it becomes brighter, and the off bipolar cells, which activates when it becomes darker. And we get a disrupted visual signal transmission in the rod-on bipolar synapses, which is that green box, when they are weak, as in the case with incomplete congenital night blindness, or broken, as in with the complete congenital stationary night blindness. And when the rod-on bipolar synapses don't pass on light information effectively, the amacrine cells can't do what they do best, which is release dopamine. And the role of dopamine in myopia progression has been studied extensively. We need dopamine to support emmetropization and normal eye growth. And when we don't have enough to regulate growth, myopia develops. So the big question that was apparently asked by neuroscientists, because it wasn't me, was whether rods or cones control the release of dopamine. And a recent study found that only rods, not cones, were actually responsible for the release of dopamine in the retina. So they are super important for more than just seeing clearly in the dark. And in fact, patients like Kai Chi help us to understand the pathogenesis of myopia. This paper hypothesized that exposure to insufficient light levels, and we know we need about 2 hours every day in young children, can lead to a similar dysfunction of the on pathway, and hence believe why myopia develops. So studying patients with congenital night blindness could actually hopefully lead to therapies like gene editing to restore rod signaling and, maybe one day even help us prevent myopia. So when things don't quite make sense, make sure you refer your patient out for further diagnosis and management. Make sure that you have a good range of optical interventions and pharmaceutical interventions to manage your myopic patients. And I think this is where my presentation ends with some key takeaways when it comes to high syndromic myopic patients. And that is that we really have to be mindful that the patterns for myopia onset and progression are different compared to typical myopia. Follow the IMI protocol. It's very comprehensive, free download from online. And myopia control should be based on axial elongation. So even if they progress slowly, that's still not a reason not to manage them. I did hear someone say that, if you have a young child, they don't provide myopia management at all because they won't progress. And I don't think that's the case for everyone. High myopia patients are often excluded from myopia trials, and this limits evidence-based recommendations. So when making recommendations for this group, make sure that you take it case by case and you try and tailorize it for them as much as possible. And when a referral is indicated, collaborate, collaborate, collaborate. Don't leave them in your room. And that concludes my presentation. Thank you all for hanging in there for the more than full hour, really. How do you make parents more confident about the myopia control lenses?
I think it's a hard question because if we have, it's firstly, we are doctor, we have experience to tell them we have some such like papers, or we have experience on the control glasses can help the children. But sometimes is not effect on all the children's. So we just tell them we are trying to find them a better way for them to control the myopia and give them the confidence that not just because of the lenses. It's also because of we are doctor and we are very confident to ourselves. We be very patient and very expert on control the myopia at this area. So we just give them one kind of solution. But if the belief of the doctor, they will follow you, but not just confident about the myopia control lenses. They are just follow your solution, something like that, I think.
I think you hit the nail on the head, Tang. I think if you're confident, it will come through, and parents are very good at picking up on it. So, and the other thing that I like to do is just to demonstrate all the, the efficacy. I do have charts in the practice. Second question, at what age should myopia management start? I put that in because there are a number of countries that ask that question. I mean, we've obviously all provided case studies on myopia management for very young children, and I don't think that there is an age. I think if you see myopia, you have to really consider whether or not they need to start myopia management as soon as possible. What do you think, Martelie?
SooJin, I think you start myopia when control when myopia starts. And it should not be linked to an age, because we all know what myopia is going to do. We all know which direction the actual length is going. So I don't wait and I don't look at the age. I start myopia management when myopia starts.
In fact, if anything, I actually saw a study of children wearing MiYOSMART lenses before they're even myopic, and they found that the axial length progression in 1 year in 5 or 6 year olds was only 0.1. rather than other kids who are progressing a lot faster. So there's even an argument being said now that maybe we should even look at myopia management before they even become myopic, regardless of age. And it depends on their risk factors that they present with when they come in with their families. What about the second? What is needed to set up a myopia control clinic? That's a very good question because, you know, the equipment and the access to optical interventions and pharmaceutical interventions and the skill set, there's so many variables involved. What do you need to set up a myopia control clinic?
SooJin, I think if you go and look at each country's minimum equipment list that is necessary to practice your profession, in a basic minimum equipment list that's usually available, you should be able to manage myopia or set up a myopia clinic. But due to the golden standards of the cycloplegic refraction, you should have your cycloplegic agents as well, not to overestimate myopia or overdiagnose it. Then, yeah, so I think if you've got a red, you've got a V8 chart, and you've got cycloplegia, you can have a myopia clinic.
Yeah, that's right. And, you know, to be honest with you, you don't really need to have a lot of fancy equipment either. You just need to be able to be very good at observing. Even basic equipment can take you very far. And in terms of monitoring for progression, it's nice to have axial length, but really we know from research that a lot of the interventions, especially if they're evidence-based, they do work. So if you prescribe it, there is a good level of confidence that you are making a difference. How do you manage high myopia in children under the age of 2? Dr. Tang, I think that's your question.
How do you manage high myopia? Firstly, most children in my hospital under the 2 years old, they have myopia is not very common. I think if we see high myopia in under 2 years old, we also very nervous about this kid because sometimes I think it's because of the genes, or sometimes it's because of they have some common with the eye disease. So it's not only we just control the myopia, we should find the eye problems, such like the retina or such like the lenses. So it's very hard, the task work for us. But the cases I show is a children who was very lucky, he can find a way to control the myopia. But today I just want to show cases, but for all the doctors, I think I'm just a beginning learner, and I want to learn more knowledge from you all. Thank you.
Yeah, good point, Han. So, you know, could recommending MiYOSMART is as a first option for a child's first pair of glasses be good enough, or should we wait to see progression? I think we all three of us would unanimously say, don't wait to see progression. How a child progresses before, and even if they progress slowly, is really no indication of how they're going to progress in the future. So just because they progress slowly previously does not mean they're going to continue progressing slowly in the future, is what I'm trying to say. And if they have a high risk for myopia, I think you need to start, at the very least, encourage outdoor time, because if they're a pre-myope with a high risk of myopia, even spending time outdoors is going to delay the onset by 2 years, and that can be massive in terms of their endpoint prescription. So what is the right age to start MiYOSMART to fit MiYOSMART lenses? I would probably say when you can find the right frame size that will fit their face, you can put MiYOSMART lenses on it. It really is more dependent on the frame than the actual age. Does binocular vision affect adaptation to MiYOSMART lenses? Martelie, you are the expert on this because you answered that question in your presentation.
Thank you, SooJin. So in practice, I haven't found a binocular case not being comfortable with the MiYOSMART lens. I know in the beginning when we started prescribing for myopia with MiYOSMART lenses, that when we had a high lack of accommodation, we were cautious to prescribe myopia, but we should always remember a myopic child is a lazy focusing patient because they don't have to focus when they look close. So if the child is, for instance, a -2, there's no accommodation needs to take place. So the lack of accommodation is usually high when you put the script on. So what I've done lately for the last 4 years is that I will initially ignore the lack of accommodation until they are on their 6 months visit. And I have to say, I haven't found one patient that hasn't improved, where the accommodation hasn't improved with the minus lenses, just due to the fact that the accommodative system now have to start focusing through the minus lenses. So I yet have to find the patient that don't accommodate with a high lack of accommodation. And then with the exophoria, if the exophoria is large, we do convergence therapy, and if it's larger than that, we can't get any fusion. Then you do have to, when the fusion is low, before we get the to full visual therapy capacity, we often prescribe slightly prism with that. But it doesn't affect the adaptation to the MiYOSMART. It's just still part of the binocular syndrome that they've got, and they would have had that symptoms with or without other glasses. Thank
Oh,
you.
thanks, Martelie. Look, we're running out of time because I'm very mindful it's now 1:32. So maybe we'll just finish off by answering that last question, which is better, MiYOSMART or Ortho-K? For me, that's a loaded question, because at the end of the day, the best intervention is the one that the child will wear and will get you the biggest compliance. At the end of the day, a lot of these interventions are really looking at doing the same thing, which is changing the peripheral blur on the retina. So the overall outcome is very similar in terms of efficacy. So I would prescribe the one that I think the child will be happy to wear. That's first. And then the other ones, what do you think? Is there anything else you'd like to add to that question?
SooJin, I think it's just in practice, it's just what's best for the patient, what they comply with the best. And because the patient base that I see is very young, Ortho-K is a very invasive procedure. Not that it does not work. It's just often the compliancy to that is much worse than the MiYOSMART. So it's just an easy option to put on glasses rather than to put lenses in. But each patient's different, and we can't say which is better. It's just the patient you see in your chair, what will be best for them.
So true. So anyway, I think we've run out of time now, and I don't want to keep people waiting. And I hope that everyone has been able to take something back to their practice that's going to be useful and practical. And if you have any questions, we'll make sure that our contact details are available online, so you can send us questions directly.